Okay. This is a very what I told you. This is the cumulative patency of the graft in symptomatic patient. As you can see, the most important is liver for LAD. This is the passport for the life. There's also on the other side you can have the saphenous vein graft and also the radial. But what is the real prevalence of CTO PCI in our regular day in the cat lab? We know from the study published from Canadian guys in 2012 in the no CABG passage we had around 80% of the CTO in the coronary angiography, but also when we have a patient that was submitted to CABG, you have a rate of occlusion around 54%. It's a very important. CABG, it's a marker of the occlusion. And what about the CTOs as a result of the CABG? You have 2 points. A patient that you have more than 9% of the stenosis prior to CABG, and the patient you have less than 79% of stenosis at the time that you perform the CABG. Do you have a new CTO in those type of patient around 45% in new CTO at 1 year and 90% in new CTO at 1 year. And also in the native vessel, if you have a limit to LAD, you have around 18% the CTO, and if you have a radial, 27%, and if you have a saphenous vein graft at 1 year, you have a 29% of the CTO in this patient. And also, with this the long-term follow-up of this patient, as you know, the long-term follow-up it's not good in terms of the death, myocardial infarction, and revascularization. And the main important point is the preoperative CTO. But why? Because as you know, in syntax 2 trial, the majority of the patient came with angina, and the patient in the surgery, about 32% of the patient didn't have a graft because the surgeon, they don't care about the graft for this type of the lesion. This is a occlusion. This is a occluded vessel and negative remodeler. They don't have a target. But also in our community, we didn't do our best because 52% of the guys with CTO, they don't outperform PCI. This is the first reason that the patient came back with angina. And also, what is the prognosis? What is the effect in the baseline of the patient there and CTO? This is clear. All cause of death and myocardial infarction, all cause of death and myocardial and PCI, all cause and cardiac death, myocardial infarction, PCI. This is clear if you have a baseline one or more CTO than to have a no CTO at baseline. And also, if you have a CTO in the baseline, if you have a new CTO in year, or if you don't have a new CTO in year, it's impacting prognosis in terms of all causes of death, myocardial infarction, PCI, cardiac death, myocardial PCI, all causes of death, and PCI. This is a new CTO. It's not the CTO. It's not the benign disease. Okay, I'm blocked. Why? I don't know. Also, we need to know that the CABG is not to work by intention to treat. Surgeon need to a good target. Often a problem with the CTO. Everyone that perform the complex PCI and to perform CTO knows that. Because sometimes you have a distal vessel that's 1.5, but if the patient, after you reopen the vessel, if there is no disease in distal vessel, the patient comes back in 8 weeks or 3 months, you have a vessel that's growing a lot, more than 2-3% of the case, you have a big vessel. The effectiveness of CABG for occluded artery is a lot unknown and may be overestimated. CABG is the first one cause of new CTO, and these occlusions are not benign. But what is the problem that you are facing when you are talking about the revascularization after the CABG failure? First of all, you have technical issues. This is a very important point. First one, this is accelerated atherosclerosis and calcification because you don't have flow behind the graft, and it's a problem because you have accelerated atherosclerosis, and the most terrifying disease, this is a calcification. This is another point very important because we have in our center we perform more than 100 CTOs per year. 25% of our patients are post-CABG failure patients. It's a great point because the problem with the surgery, you have a lot of anatomical distortion, and someone that to embrace the program of a CTO PCI, you need to take into account this because it's not easy to deal with. Also, sometimes you need to recanalization the graft because it can use as a conduit for the to do the retrograde and to do antegrade procedure. And also, sometimes you need the grafts as interventional collaterals. But what is the problem when I'm facing when the patient has a CTO and they have the first after failure CABG? The main in my mind, the first question that I ask for my colleagues, for the interventional cardiologists, the young one, and also the clinical cardiologist, it is possible to do anything in a vessel because, as everyone knows, we don't have a very good result in PCI in the graphs. This is a main question. Is it possible to do anything in a vessel? And the second point, it's very important because we know, because we have a lot of randomized clinical trials, that the best that we have for the patient is complete revascularization. The complete revascularization, it's not the same in the patient with 87 years old and after that a patient at 47 or 56 years old. This is a very important. You need to think about complete versus incomplete revascularization. I'm going to share my case. This is 82-year-old man. This is a former smoker, history of dyslipidemia, non-diabetic, insulin-dependent required. He was admitted in 1985, it's so long ago, with inferior myocardial infarction. At that time, you used staphylococcus. He performed the coronary angiogram and the Joâo and 3 vessel disease. And after that, because this is 1985, you don't have a lot of material, don't have a lot of experience, this patient, yes, we performed the CABG, aortic LAD, aortic obtuse marginal, aortic PD with a saphenous vein graft in January 86. This patient came back with new onset angina in CC2 in March 2022. The EKG shows a senior treatment and key waves in inferior leads, and the echocardiography transthoracic shows the inferior akinesia and hypokinesis of two types of the anterior and lateral wall with ejection fraction than 32%. We recatheterize this patient who has a 3 vessel disease, CTO of mid LAD, CTO of mid RCA, and critical stenosis in the blood circle. And as we expected, all of the saphenous vein grafts are occluded. We perform nuclear scintigraphy in this patient to show us the inferior necrosis and large anterior and lateral wall reversible defects, more than 10% of ischemia. This is what you have in angiography. We have some occlusion of mid RCA with the big epicardial channel to the LAD. You have a LAD, an ambiguous proximal cap with a trifurcation, the first diagonal and the big septal, and also we have a critical stenosis of the circle. Which is the problem that we have. The first one, it's the revascularization. Is it possible to do in this patient or in the patient with 82 years complete revascularization versus incomplete revascularization? We can think about, we discussed this patient, is it possible to do re-CABG or to do this, to send this patient for PCI? This patient was presented in our team discussion. It's turned down for re-CABG, and we decided to do the LACTO first one, and after that we performed the stage PCI of the left suck. We use in this patient to hybrid approach, and the main points you have to discuss is it always the proximal cap. The proximal cap it's ambiguous, and you have we don't know the length of the lesion, but you have a very good distal connection from the epicardial from the right to the LAD. First, this is why we take as a primary intention to do this procedure as retrograde approach primarily. This is we can do as a retrograde through to lumen, or you can do as a retrograde with dissection reenter with the reverse cut. This is a dual injection. Our setup is right radial XV 3.5 and 7 French to left main, and right femoral IL1 7 French to RCA. As you can see in dual injection, we have a big connection, a very good connection from the epicardial, the right to the LAD. This is some ambiguity of the LAD. Probably the lesion is long. We have a trifurcation, as I've previously mentioned. We start we do start our procedure as primary retrograde approach. You use epicardial collateral, you use a Corsair 150, you use a fielder XCR, and you go to explore this epicardial collateral. This is what you have. We did some work. This we didn't like very much. The behavior of this wire in the retrograde approach to the LAD. Also, we use a Corsair 185 in retrograde setting. Use the pilot 200, and as you know, you have the problem with the ambiguity of the distal cap, and also in the ambiguity in the proximal cap, because we have also ambiguity in the proximal cap, as we have shown priorly. This is the problem, very important, and you take account when you are treating the patient post-CABG. Is probably you are faced with some anatomical distortion. This is very important point. How can we overcome this ambiguity of this movement of this wire retrogradely? This is a very important point. This is you can do IVUS, but the most important probably is to knuckle. It's a safe procedure. You can overcome the ambiguity of the distal cap, and also you can overcome the ambiguity of the proximal cap. This is what you did. We just push the fielder XTR. This is what we have done, and also we perform a knuckle in the LAD, the proximal LAD, and after that we did a tip injection because the guide wires and the microcatheters are in completely different space and this is not the same space. This is why I have changed to my setup. And it's very important point when I perform tip injection. I understand we didn't have a long occlusion, but we have a long anatomical distortion. This is what we have to work. We need to work in the retrograde approach to connect the antegrade approach. We need to take out of the gear in the diagonal and do the reverse, and you need to make the connection between the antegrade and retrograde guide wires. This is what we did. Okay, another point that's very important in this complex case, it's how to understand the behavior of the retrograde wire. It's very important. We perform eleocranial, and you are seeing it is a lot of anatomical distortion. This is how can I connect these two different wires. It's very, you can appreciate the difference in the movement and the knuckle of the retrograde wire. Once again, as you have mentioned, we did some work to do the connection. We have a small perforation. It's very, very easy to manage with. And after that, you go with the knuckling. We perform the knuckle wire in the antegrade and the retrograde wire. At that time, you use a guide assistant reverse cut, as I mentioned, but it's a very important that they use the guide extension, because the guide extension can assist me as a reverse cut, but also we have a long lesion, tortuosity. We need probably use it as in assist for the POBA and for the stent implantation. This is a good device. You need to. This is one of the best devices that we have in our toolbox. This is the guide extension. we perform the reverse cut. At that point, we with the capture technique, we go with the retrograde wire in the guideliner. We do externalization with RG3. We do some POBA, different segments of LED. It's you can appreciate how is the anatomic distortion. It's probably it's a problems in long term follow up of this patient because it's a stress the zone of the vessel. You can have rupture, you can have aneurysm, something like that. It's very important at that point to keep the patient true to room and on the session re-entry. We use, as I've mentioned, the guideline and assistant stenting. We implant 3 stent, 2.5, 328, and 3.5, 24. And this is my final result in LAD. As you can see, not bad results at the end of the procedure, but look at this stress in the anatomic distortion, the distortion for the surgery. This is, we perform the complete revascularization weeks after the first procedure. We implanted 3.5 by 26 regulating stent in the sort. We performed the complete revascularization. Okay, what is the prognosis of after PCI in this type of patient? It's very important to do the complete vascularization. If you are looking in the left, the cumulative mortality, it's bigger that you have incomplete versus complete vascularization, and you have one or two or more region for the incomplete vascularization. Sorry. What is the prognostic after PCI in less post CABG? If you are talking about multi-vessel or in the graft, it is very important because if you have a multi-vessel PCI or single vessel PCI. And also, what is the prognosis of the complete revascularization? We had the better outcome for this patient. This is mainly for the young guys, not for the older guys. I will finish my talk as a take-home message. PCI RTA BG failure and worse lesion characteristics. It's a very important point, and are technically demanding. We need to be prepared. We need to have experience with some anatomical distortion. By default, we need to do complete revascularization. Should be considered mandatory in multivessel disease and CTO practice. CTO PCI follow hybrid approach must be necessary. You can do mastering the integrated wire approach, retrograde. You need to do as integrated dissection reentry and retrograde dissection reentry with reverse cut. It's a very important point. You need to take and to do all of the procedure because it's one of the master of the hybrid approach. Knuckle wire is safe and effective and makes possible to do some difficult cases. This is how I show in different ways, retrograde and antrograde, how the knuckle can help me because I was an ambiguous proximal cap and bifurcation, and also we have the distal ambiguous cap. This is the knuckle that saved me and that let me do the case in the safe and efficiency and efficacy at the end. And almost every lesion can be treated provided you have the right skills and the tools. We need to have, as Nice told in the previous talk, we need to have the skills, we need to have the tools, but you need to have a team. In each moment, we need someone from some of our colleagues or from team, our cat lab, then talk and stay with us, and you need to manage all of the procedure. Thank you very much for the invitation, and thank you very much for your patience.